the process of sleeping a patient using anesthetic to transition the patient from fully awake to the unconscious state of general anesthesia. For sedation goal is to give patient comfort, for pain control, for anxiolysis to make patient calm, and amnesia to blunting adverse autonomic and hemodynamic response, to facilitate mechanical ventilation, to facilitate nursing management, to reduce oxygen consumption, and to avoid self-extubation. For level of sedation and analgesia, sedation is a continuum which extends from normal alert consciousness to complete responsiveness. Sedation and recovery move patient along this scale, but it's difficult to accurately assess the precise degree of sedation at any one time, and even harder to maintain a patient at predefined target level. So the American Society of Anesthesiology, ASA, use this level of sedation and analgesia to define the sedation level. So with the minimum sedation or anxiolysis until general anesthesia. So this level, we can use level 1 until level 4 also. So I will explain one by one. For the minimal sedation or anxiolysis, a drug-induced state during which patients respond normally to verbal command, although cognitive function and coordination may be impaired. Ventilatory and cardiovascular function are unaffected. Untuk moderate sedation or analgesia, conscious sedation, a drug-induced depression of consciousness during which patient respond to purposely to verbal command, either alone or accompanied by light tactile stimulation. No intervention are required to maintain a pattern airway, and spontaneous ventilation is adequate. Cardiovascular function is usually maintained. For deep sedation, analgesia, responsiveness, a drug-induced depression of consciousness during which patient cannot be easily aroused after repeated or painful stimulation. The ability to independently maintain ventricular function may be impaired. Patient may require assistance to maintain airway, and spontaneous ventilation may be inadequate. Cardiovascular function usually maintained. General anesthesia, a drug-induced loss of consciousness during which patients are not rousable, even by painful stimulation. The ability to independently maintain ventilatory function is often impaired. Patients often require assistance in maintaining a pattern airways, and positive pressure ventilation may be required because of depressed spontaneous ventilation or drug-induced depression or neuromuscular function. Cardiovascular function may also be impaired. So that's about level of sedation and analgesia. This is a type of sedation and induction agent that commonly used in ED setting. We have midazolam, we have thiopental, ketamine, propofol, etomidate, dexmedetomidine or Precedex, and fentanyl. So for midazolam, for sedation dose about 0.07 to 0.1 mg per kilo titrating dose, or we can use IM 0.07 to 0.08 mg per kilo. For induction, IV, we can use 0.1 to 0.2 mg per kilo. The onset of action about 1 to 3 minutes, and the half-life 1.5 to 2.5 hours, and duration of action is 30 to 60 minutes. For thiopental, the sedation dose infusion 0.04 to 0.2 mg per kilo per hour. For induction, we can use IV 2 to 5 mg per kilo, and the onset of action 30 seconds. Half-life 3.4 to 22 hours, and duration of action is 5 to 15 minutes. For ketamine, the sedation dose is 0.2 to 0.75 mg per kilo. For infusion, we can start 5 up to 20 mg per kilo per minute. And for IM, we can use 2 to 4 mg per kilo. For induction, we can use IV 0.5 to 2 mg per kilo over 60 seconds. IV infusion 10 to 50 mg per kilo per minute, or IM 4 to 10 mg per kilo. The onset of action about 30 seconds. for IV and IM about 2 to 8 minutes. The half-life 2 to 5 hours, and the duration of action is 5 to 10 minutes. For propofol, IV infusion for sedation is 1 to 3 mg per kilo per hour, maximum 4 mg per kilo per hour. For induction dose, for propofol, we can start with 1.5 up to 2.5 mg per kilo. But for elderly, we can start 1 to 1.5 mg per kilo. For infusion, we can start 4 up to 12 mg per kilo per hour, or in elderly, 3 to 6 mg per kilo per hour. The onset of action is 30 seconds, the half-life 40 minutes, the duration of action 3 to 10 minutes. For intermediate, there is no sedation dose, but for induction, we can start 0.3 mg per kilo or 0.15 or to 0.2 mg per kilo in elderly. The onset of action is less than 1 minute. The half-life 2 to 5 hours, duration of action 5 to 10 minutes. For Precedex sedation dose, we can start with IV infusion 1 gram per kilo for 10 minutes. Then subsequently, we can titrate the dose from 0.2 up to 0.7 gram per kilo per hour. The onset of action is 15 minutes, the half-life 2 hours, and the duration of action is 1 to 2 hours. For fentanyl, for sedation dose, we can use start 0.5 to 1 mic per kilo, or infusion 0.05 to 0.1 mic per kilo per hour. For induction dose, IV kita boleh start 0.5 to 1 mic per kilo. Onset of action is less than 1 minute. The half-life is about 4 hours, and duration of action is 30 to 60 minutes. Okay, so what's the effect of this the sedation agent? For midazolam, the main action is sedation, amnesia, and anxiolysis. No analgesic properties. The side effects are predominantly cardiorespiratory depression, hypotension, respiratory depression, and apnea. For thiopental, the main action is hypnotic and anticonvulsant. No analgesic properties, but the side effect is potent respiratory depression and negative inotropic agent. For ketamine, the main action is dissociative anesthesia. It's a combination of profound analgesia with superficial sleep. It does not affect pharyngeal reflexes, means tak boleh cause vomiting lah. The side effect can cause tachycardia, increase blood pressure, IOP or ICP. It can cause it's also bronchodilator agent, and can cause emergent phenomena or post-sedation agitation. For propofol, main action is sedation, amnesia, and hypnotic. No analgesic properties. The side effect is hypotension, respiratory depression, profound bradycardia, and also bronchodilator. For intermediate, main action is hypnotic. No analgesic properties. The side effect is relative cardiovascular stability and may cause tachycardia in higher dose. For Precedex, the main action is sedation, anxiolysis, and analgesia. The side effect is hypotension and bradycardia. And lastly, for fentanyl, the main action is analgesia. It can obtain the cardiovascular responses to laryngoscopy and intubation. And the side effect is potent respiratory depression, nausea and vomiting, and may cause chest wall rigidity or wooden chest phenomena. So, from this effect, we can know there's a certain agent can be used as superior to other agent. Example, in certain condition like hypovolemia with hypotensive lah. So best to use etomidate or ketamine, because etomidate is a relative cardiovascular stability and ketamine may cause increased blood pressure. But the best to avoid thiopental and midazolam. For isolated closed head injury with normal or high BP, the medication that we may use is thiopental, etomidate, or midazolam. Suggest to avoid ketamine, although current evidence suggests that ketamine help patient in increased ICP by maintaining cerebral perfusion. For asthmatic patient, we can use the agent that have bronchodilator effect, such as ketamine or propofol. So now we go for procedural sedation and analgesia, commonly referred as conscious sedation or procedural sedation. It is performed in ED to alleviate anxiety, decrease pain, and provide amnesia to patient undergoing painful painful procedure or diagnostic imaging. The goal is to achieve moderate sedation, and the ideal agent for PSA is able to provide anxiolysis, analgesia, and amnesia in a rapid and predictable manner without side effect and with a quick recovery phase. For pre-PSA assessment, we need to include focus history, past medical and anesthetic history, and physical examination to look for anatomic variant that may put patient at risk of airway or voluntary compromise, such as obesity and obstructive airway disease. This ASA classification is developed to help clinicians to predict operative risk or to know patient is a good candidate for anesthesia. So we can divide into ASA 1 until ASA 6. ASA 1 is a normal healthy patient. ASA 2, patient with mild systemic disease such as smoking, pregnancy, obesity, well-controlled diabetes or hypertension and mild lung disease. ASA 3 is a patient with severe systemic disease that is not incapacitating, such as poorly controlled diabetes or hypertension, COPD, ESRF, CCF with EF 25 to 40%, history of EIA or CAD. ASA 4 is life-threatening, severe systemic disease, such as recent history of MI or stroke, ongoing cardiac ischemic or severe valve dysfunction, implantable cardioverter defib, EF or EF less than 25%. ASA 5 is moribund patient not expected to survive without procedure, such as ruptured abdominal or thoracic aortic aneurysm, ataupun ada ICB with mass effect. I'm so sorry, ayam ni, actually ayam belakang bilik saya ni, dia bising sikit. ASA 6 brain dead patient undergoing organ harvesting. Okay, so pre-procedure fasting, many PSA guidelines opted for pre-procedure fasting. ASA consensus recommend that patient not to eat solid food for 6 hours or drink clear liquid for 2 hours prior to PSA or general anesthesia. But from the American College of Emergency Physician guideline, do not consider recent food intake as contraindication, although it may affect the timing and target level of sedation. So if patient tu kita rasa dia ada risk of aspiration, we may use medication that can preserve protective airway reflex such as ketamine. For monitoring, we need to monitor for pulse rate, SpO2, respiratory rate, blood pressure. So we need to ready for supplemental oxygen, suction. Senang cerita dah kena ada ready juga emergency trolley in any case kalau patient collapse after we give sedation lah. And the titrating dose based on sedation scale will help prevent over sedation, under sedation, and restlessness and agitation. So common tool kita boleh guna revised Riker sedation and agitation ataupun Richmond agitation sedation scale. Ini contoh revised Riker sedation and agitation. Kalau in PSA, kalau patient tu positive 3, maksudnya patient tu tak sedated lah. Kalau negative 3, unresolvable tu over sedated. That's the example how we use this scale, sedation scale. So for ketofol, it's a combination of ketamine and propofol in 1-to-1 ratio. Cara nak guna, boleh guna 20 ml syringe, kita combine ketamine 10 mg per ml and 10 ml propofol, ataupun kita guna 2 separate syringe. The overall dose is 0.5 mg per kilo. So the theoretical benefit, lower dose of each sedative result in decreased dose-related side effect. Opposing action may moderate the potential side effect of cardiorespiratory depression, emergency phenomenon, nausea and vomiting. Discharge criteria, monitor patient until return to baseline mental status. Most adverse effects occur during the first few minutes of sedative administration, and adverse effect more than 5 minutes after completion procedure are rare, about less than 1%. So for special population, in elderly, we know that ventilatory drive and ability to maintain airway is reduced. Ada juga fasting and denture to be removed. Aspiration increase due to reduced gag reflex and gastroesophageal sphincter. So suggestion, kita boleh guna etomidate because of cardiovascular stability or use propofol with half dose. Kalau children, preferable to use IV ketamine 1 mg per kilo. More than 90% adequately sedated, but ketamine is contraindicated for children less than 3 months old. Kalau patient tu ada difficult IV line access such as autistic child, we can use IM. Kita guna IM ketamine 2 to 4 mg per kilo combined with midazolam to reduce emesis and emergent. In mechanical ventilated sedation, we commonly use analgesia first sedative like morphine or fentanyl. But kalau require another sedation, we can add on propofol or Precedex because lower incidence of delirium. But in hemodynamically unstable patient, we can add on IV midazolam. Initiate at 1 mg per hour and titrate by 1 mg per hour every 30 minutes to achieve sedation goal. Or we can use high dose fentanyl alone. Initiate at 50 mg per hour and titrate by 25 mg per hour every 15 minutes. And maximum dose is 500 mg per hour. So now we go for paralysis agent. Definition: paralysis is the impairment of or loss of voluntary muscle function or of sensation in a part of area of the body, usually caused by a lesion or disorder of the muscle or the nerve supplying them. So the function of paralysis agent is to improve patient ventilator synchrony, to improve or enhance gas exchange, to diminish the risk of barotrauma, to helpful during non-conventional ventilatory strategies such as permissive hypercapnia, prone positioning, and or high PEEP, to manage of increased ICP, a treatment of refractory status asthmaticus, to reduce oxygen consumption, prevention of shivering in patient receiving therapeutic hypothermia after cardiac arrest. So paralysis agent can be divided into depolarizing and non-depolarizing. Depolarizing is a prolonged binding to acetylcholine receptors such as succinylcholine or scoline. Non-depolarizing is a competitive inhibitor of the postsynaptic receptor. Ada dua jenis, satu benzylquinolinium, example like atracurium, the common one kita use, or aminosteroid, common kita guna rocuronium. So the succinylcholine dose is 0.5 to 2 mg per kilo. For infusion, 2 to 15 mg per kilo per hour of 0.1% solution. We can use IM juga 2.5 mg per kilo or sublingual 2 mg per kilo. The onset of action 30 seconds, the half-life 2.7 to 4.6 minutes, and duration of action is 3 to 5 minutes. For rocuronium, the competitive antagonism of acetylcholine at N2 receptor postsynaptic. So the dose is 0.6 mg per kilo for intubating dose. Subsequent dose is 0.1 mg per kilo or 1 mg per kilo for modified RSI. For IV infusion, we can start 300 to 600 mg per kilo per hour. The onset of action 60 seconds. The half-life 73 minutes. The duration of action 8 to 17 minutes. Nearly 1 hour if kita guna 1 mg per kilo. Kalau atracurium, dia punya starting dose, dose dia 0.3 to 0.6 mg per kilo for intubating dose, 0.1 to 0.2 mg per kilo for maintenance dose, for IV infusion 0.3 to 0.6 mg per kilo per hour. For onset of action 90 to 120 seconds, for half-life 17 to 21 minutes, and duration of action 15 to 35 minutes. The effect of agent for paralytic agent for succinylcholine like bradycardia, cardiac arrhythmia, fasciculation, increased serum potassium, increased IOP, marina hyperthermia. Kalau rocuronium, minimal cardiovascular effect can cause apnea. Kalau atracurium, minimal cardiovascular effect, not effect on ICP or IOP. Lower esophagus sphincter pressure preserved. For how we monitor the depth of paralysis, first we can observe the skeletal muscle movement. Second, we can look for sign of respiratory effort, or maybe have ventilator asynchrony, elevated peak airway pressure, or inspiratory triggering on the ventilator. In OT setting, if we have the capnograph, we can see notching of the end-tidal carbon dioxide waveform, or we can use peripheral nerve stimulator ataupun trend of 4 monitor. So this is my reference for this slide. I think that's all from me. If you have any question. think maybe I can pass this CME to Dr. Alex back.
Okay, thank you, Dr. Afiq. Now we open up to the floor to see if any questions first. Before we go to the questions, maybe the EPs can put up, can giving some inputs so that we can see. And plus, we will want to know what's the name of the ayam as well, because the ayam has also contributed today to our CME. Either the ayam today going to become curry or the ayam is going to be forgiven lah. It depends on Dr. Afiq lah today. So we'll wait for the EPs. Okay, Doctor, any EPs would like to give their input first?
Assalamualaikum warahmatullahi wabarakatuh and very good morning to all. Afiq yang present tu. Boleh dengar kah?
Boleh, bos.
I think this is a very good slide. So whenever you want to refer back to sedation and paralysis, this is a good slide to refer to. So well done. And right, sorry. Medication, we should know what is the why we prefer one drugs over another lah. So especially in terms of sedation and paralysis. So I think maybe most of the senior ones memang dah tahu kan. Contoh kenapa you want to use midazolam over ketamine contohnya. So you have to know why you choose that drugs. And the most important thing is you are familiar with the drug when you want to use it. Okay, that is one of the factors why you use a drug over another. Okay, I think I've summarized in a very nice and precise way in the slide, so you can always refer back lah untuk study balik. Okay, I think that's all. Anyone else nak tambah?
Hello. Okay, Assalamualaikum, selamat pagi. Terima kasih Alfian for the very informative presentation. I think most of us are familiar with all the drugs that has been presented by Alfian. Like what Dr. Afiq said, it's all about recognizing what the patient requires, recognizing what medication that you want to use in and out, and know the complications and know how to manage the complications. Yeah. In terms of all the sedative agents, Alfian has put down a list, a very good list that we can refer to, including the bolus and infusion doses. But when, like I mentioned earlier, like I mentioned before, well, those the drug of choice, it all depends on your patient. So you need to assess your patient, assess patient's airway, and assess patient's hemodynamics. And if you think that patient, for example, who's obese and hemodynamically compromised, and choose the agent that produces lesser side effects. And if you are unable to intubate those patients, make sure the agent that you use can be reversed and have agents that you can reverse the effect. Contohnya macam paralytic agent. So instead of using rocuronium, you use susamethonium, because even though it doesn't have a specific antidote, reversal agent, but you can wait for at least 30 seconds for the patient to regain its respiratory effort. Right? Kalau misalnya if you want to consider using rocuronium, always bear in mind that there will always be a risk of unable to intubate the patient, and you will always have the risk of losing patient's airway. When that happens, you need a reversal agent, which is Sugamidex, which is very expensive, and kita ada di DCR. Yes, so kalau boleh, it's better not to use for those who are still new in the department. It's good to know what it is, but it's very dangerous when you don't know how to use it. Okay. Yeah. Ada apa nak tambah? Terima kasih. One info that I would like to share. Alfian did touch a bit on PSA, procedural sedation and analgesia. Selalunya yang kita akan pakai adalah ketamine and propofol, ketofol. And so whenever we perform sedation, procedural sedation and analgesia, assessment of patient is very important. Preparation of equipments, preparation of airway equipment is very important because of the risk of losing patient's airway in the midst of doing the procedure is high. So always have your airway trolley, your bag of masks ready, and vital signs pre, during, and post is very important. And you need to know the risk and the complications that develop during PSA. Yes, PSA doesn't really cause that much complications. Contohnya macam post-operative nausea and vomiting, emergency delirium, and hypotension. Yes, even though it's rare, bukan rare lah, even though it's not that prevalent, but there's still risk. Right? Just one thing to share. Untuk post PSA monitoring, there's actually a scoring system that you can use. Dipanggil SPEEDS criteria, SPEEDS. Boleh Google lah. So ini saya buat masa saya punya dissertation. So SPEEDS criteria, dia nak tengok sama ada patient is ready to be discharged or not. So based on a lot of studies and including my studies, including the study that I did, with the use of SPEEDS criteria, di mnemonic, saya pun dah lupa apa mnemonic tu, you can safely discharge patient paling awal sekali 5 minit. 5 minit after PSA, patient can be discharged safely and there's no complications develop after 24 hours. So you can look it up in the internet. So dipanggil SPEEDS criteria, SPEEDS criteria. Thank you.
Anyone else nak tambah anything?
Okey, ada siapa-siapa lagi yang nak beri input?
Soalan Dr. Aziz. Ini dapat nampak soalan ni. Soalan soalan Dr. Aziz pun about protocol of PSA in LED. Anyone want to answer about that?
Okey, thank you for all the input. Soalan-soalan pun saya rasa dah mostly dah terjawab oleh Dr. Umar. Kalau ada apa-apa soalan boleh PM terus ke Dr. Afiq Alfian ataupun ke grup C yang telah membuat input untuk slide. Ataupun boleh approach mana-mana Masters IFR Camp student lah. Diorang pun boleh tolong, no problem. So dengan itu saya rasa kita akhiri kita punya CME pagi ni. Attendance tu nanti saya akan ambil. Kepada siapa yang tak tukar nama tu good luck lah. Saya tak kenal siapa Zoom user. Saya tak kenal siapa itu iPhone saja. So saya nasib lah, minta maaf lah, saya tak tahu siapa. Kalau sempat tukar sila buat sedemikian sebelum saya end session ni lah. Announcement wise tak ada announcement. Kalau ada apa-apa kita akan inform dalam WhatsApp lah. Okay. Sekian, terima kasih. Kita semua boleh end session. Thank you Afiq Alfian for your presentation. Kita akan next year lah kita akan jawab soalan melalui Google Classroom lah. Right, thank you.